I'll take you to 2017, and the union for doctors is called what? KMPDU, Kenya Medical Practitioners and Dentists Union.
Yes.
The Secretary General in 2017 was Ouma Oluga, and he carries the badge as the Secretary who led the union and the doctors to the longest running strike in the country, 100 days of a strike. He was jailed for it. They were pushing for better services, for better healthcare, and they were saying it's not just about us doctors and the welfare of doctors. It's about our patients. These are our people, our family members, and what they get, the quality of healthcare that we get in this country. Today, Ouma Oluga is a principal secretary for medical services. So he's right there at the helm of government implementing what he was demanding to implement, and he's our guest. Daktari, good morning.
Good morning. How are you?
Very well.
Yes.
Karibu sana, and thank you for joining us. We're going to have a lot of questions to ask you within a very short time. So it's like a quick fire.
That's all right.
But you're healthy enough to tell us about everything.
That's all right. I've been through a lot of fire.
Very
Yes.
good. Very good. Jano will welcome you with the day's quote.
Yes. Today's quote is by Lima Bowie. She's a Liberian peace activist. She's a social worker and has been credited with moving one of the largest women's movements on the continent that took Liberia out of their conflict. Now, in 2012, in a summit in New York, she said, "You can never leave footprints that last if you are always walking on tiptoe."
Exactly.
How do you translate that?
I think Latif has already just mentioned that. I don't tiptoe at all.
Yep.
Completely. And but also, I'm very passionate about healthcare and have been privileged to get opportunities to push for things that matter throughout my life. I happened to be a student leader. I was the president of medical students in the whole country, and that time we opened a lot of opportunities for medical students to do attachments abroad. Actually, part of the passion I got was because I went to so many countries and saw so many healthcare systems, and I always had the fire in me. Can healthcare systems work? I led doctors for 8 years. That's a lot. And the only CBA that still exists up to now, any salary that any healthcare worker is earning in this country, I negotiated it. So I know it very well. And I know that it is enough. That's why you've not seen them asking for more. You've just, so now I also know that it is enough for them to serve patients well. And so now I'm on this side to make sure that they serve patients well. And I was in Nairobi, NMS, you know, I was in charge of healthcare in Nairobi. We built 32 hospitals. We increased our patient attendance from 2.5 million people to 6 million. Revenue improved when I was there. Maternal mortality reduced by 50%. I was given an international award in 2021, October, for Circle of Excellence Award. The issues that relate to health workforce, I'm the one who recruited the 7,400 community health promoters in Nairobi. When I came there, I found only 3,000. And so I don't tiptoe at all. And now I have this extraordinary opportunity given by His Excellency the President Ruto to implement his agenda. The agenda that we are talking about is the agenda of His Excellency the President. And he's also very passionate about healthcare. I think that's one of the 5 pillars for the economic transformation, the bottom-up economic transformation. And I'm extremely privileged to be part of the administration that is now implementing Taifa Care. And that's what we are here to talk about today.
Yeah. We'll begin with just looking at the people that you represented, doctors. There's some medics who were hired after the COVID, or during the COVID period, and they were called UHC workers. They were deployed to the COVID-19 front lines, and they've been pushing that they get absorbed. Now, during the agitation for absorption, it emerged that there were very many on paper who did not exist physically as human beings. Up to how many ghost workers did you talk about? 8,571 were UHC workers, but over 3,000 of them were declared as ghosts. You and your cabinet secretary, Eden Duale, said, we are actually going to interrogate this and unearth the ghosts. So how many ghosts have you found?
So thank you so much for this, and thank you, Nation Media Group, because I think you also went round and you carried the headline of saloonists and plumbers. I hope that you have their names and you can help us unearth this. But we have done our verification exercise. And out of, so this, it was supposed to be 10,000 workers. First, it was supposed to be 2 phases. So phase 1 was supposed to be 5,500 workers, and phase 2, 4,600, so around 10,000. And then it came down to 8,500, and then eventually 8,000 were hired. And then as time went by, others left, others got greener pastures, others were absorbed, and so it became 7,800. We have done our verification right now. We are at 7,200. So around 600 that we could not find in the county headquarters. And out of that, we have verified their education credentials. We've verified where they work. And we have also solved the problems, because the problem was that they wanted to be absorbed on permanent and pensionable. Together with the cabinet secretary, we presented a proposal to the National Assembly that was approved. We got a budget of 6.2 billion. We wanted to transfer this budget to the county governments. The county government said, wait a minute, don't give us yet. So we invited the Auditor General to do the audit. We have also done our own verification together with the Council of Governors. The verification is now complete. We are in the process of converting them from permanent to pensionable, but only those that are in the facilities and are serving patients, not people who are saloonists and plumbers in hospitals. And we are very categorical with them that first and foremost, you must have the right credentials, the academic documents that document you as a health professional. Number 2 is that you must be registered and retained by the regulators. Number 3 is that you must have been among those that were employed through the advertisements that were made by the Public Service Commission, and you must have had a contract with the county government, and you must be present in a facility right now serving people. So that exercise is going on. Of course, there is, after the verification, now there is a bit of noise, because 600 people who are ghosts are a lot. Yeah. So 600.
What does that mean, that they are ghosts? Because you
Ghost
verified
means that
7,200, you found actual human beings, and you could associate them with a health facility. Right?
7,200.
Yeah.
And then 600 are on paper, but you did not find the actual human beings.
They did not show up. They did not show up. So there were 2 levels of verification. One is that the teams were going to the county headquarters and calling all UHC workers to come. So once you come, you present your papers, and they look at the documents that we have. We have a payroll, so we have documents. The county governments have documents because the contracts have been issued by the county governments. So the physical person has come, the Ministry of Health has come with our documents, the county governments have come with their documents, so the 3 must tally. So out of 7,800, those documents, the 3 of them tallying, is 7,200. And that person who has come, we must take you back to the facility so that the in charge of that facility can say, indeed, this is a nurse here. And we must go to the call rota or the duty rota and see that you have been on duty for at least a year. So it was a very vigorous exercise. It's extremely practical. There's no cheating it. We have to go there and see that even if you are off today, you must have been on duty last week.
Right.
Right. So the 600?
The 600, yeah.
And so the 600 is not there.
Is it that they came and their documents didn't tally?
No, the
or
600.
they didn't come?
Yeah. So there are about 7,400 thereabout that came, but the documents do not tally. Or, so 7,400 came, but but around 200 that either documents don't tally or you can't verify whether you've been at work, So those ones are still under scrutiny. But the ones that we have confirmed are about 7,200. Yeah.
And the ones who are still under scrutiny, if you're a ghost worker, correct me if I'm wrong, you're still being paid.
So this is part of what we have been correcting. Remember that the payments have been coming from the Ministry of Health, right? But the contract was issued by the county government. The hospital is managed by the county government. So this has been part of the gap that some of these people have taken advantage of, because your salary is at the Ministry of Health, but you're being supervised by the county government. So there is that gap there. And that is why the cabinet secretary was extremely categorical that the payroll must be managed by the county government.
Okay.
And we will do that. After this verification exercise, we have agreed with the Council of Governors. They had told us to wait a minute. This payroll was supposed to be with the county governments by 1st of July. Through engagement, they requested us to wait so that we give them the payroll when we have also transited them to a permanent and pensionable terms. And that will still happen. Yes.
Maybe you spoke to it and Ikani Peter. There were also UHC workers contracted by national government.
Yes.
Have those been verified as well?
Yeah, those ones have been verified. The UHC workers that were contracted by national government, basically what you mean, all UHC workers the advertisement was done by national government. The applications went to Public Service Commission. The Public Service Commission decentralized this data to county public service boards now to do the actual interviews. It's like I put an advert today, I get all the applications, but I send you the applications now to conduct the interviews and pick. So the Public Service Commission put up the adverts, collected all the data, and then as per the counties, sent the data to the county public service boards to do the interviews. That is how it was. But there are those that were interviewed and hired through the Public Service Commission and then placed in our national referral hospital like Mathare or some of the national installations. So yes, they have also been subjected to this verification. They have also been subjected to the audit, and the process is entirely the same for all of them.
Any discrepancies, ghost workers, with those who are contracted by national government?
No. There were only 95 of them.
95 discrepancies.
95?
No, only 95 workers.
UHC.
Only 95 UHC workers, and you accounted for all of them.
All of them, yeah.
The healthcare workers' strikes still remain. Beyond salary, what deeper structural issues can you admit?
There have been no strikes, I think, since we were here.
Okay, let's call it.
There have been no strikes. We've sorted out internship
Clinical
issues.
workers.
Yeah.
We've sorted
Clinical
out
officers.
the CBRS.
You know, it's not only doctors.
That are,
I said healthcare workers.
Yes.
Yeah, which
Nurses,
ones?
clinical officers.
Which nurses? Nurses were to go on a strike. They called off because they met with the cabinet secretary. He sorted out all the issues to do with their CBA. The clinical officers, I met them last week. There is absolutely zero strikes. We've healthcare workers right now. All their issues have been sorted out. And we continue to engage with them, the associations. Yesterday we were with the Pharmaceutical Society of Kenya engaging on issues about staffing for pharmacists because, as part of what we launched, we have what we call a product catalog. That product catalog must be administered by qualified professionals called pharmacists and pharmaceutical technologists. And so we've been engaging with the workers. There has been zero strikes. I think the group that...
Zero strikes from when?
For the last 3 months that we've been in office.
Yeah,
There's been zero strikes.
It's important to. I was waiting for him to say.
Yeah,
It's
zero
within
strikes.
Within your
And-
100 days of office.
Yes, and we've sorted out these issues very deliberately. I think I may need to mention the UHC model that His Excellency the President has established has 4 key pillars or priority areas. One of those priority areas is the health financing. Under the health financing, domestic resource mobilization is paramount. It's very important, okay? That is why the Social Health Authority has been established to mobilize resources domestically. Why? Because Kenya was rebased as a lower middle income economy. Right now, we are number 6 largest economy in Africa. So if Kenya goes on a begging bowl together with a poorer country, of course the poorer country gets it.
Yeah.
Okay? They'll say, your people are not as poor. Can you do something? Let's help those who are really in need, okay? And so, and you've seen now there's even a deeper problem with the shifting donor funding. The US government withdrew some of the funding that has been there for HIV, TB, malaria, family planning, nutrition, vaccination. And you've also seen FCDO as reprioritized. Actually, the word is deprioritized health. You've seen the issues relating to the Global Fund, where we are now 6.9 billion down. You've seen the issues that relate to other donations that have been coming, support that has been coming from multilateral organizations, basically the UN agencies. So we must now fund our healthcare by ourselves. So funding our healthcare by ourselves requires that we establish a very strong, stable institution that is able to collect our own resources. And that's where the Social Health Authority comes in. So health financing, a very key priority in this UHC model we call Taifa Care.
Just before
Number
we go
two,
to the next thought, actually, on the
Number
health
two is the
finance.
health workforce, because you've just asked me about the health workforce.
Yes.
So if you don't sort out the issues of the health workforce is the bloodstream of the healthcare system. So we have financing. We must have people in the facilities that treat patients. That's why health workers are very important for us. That is why we would rather postpone any other thing we are doing and engage with our health workers. And we do that. And we do that boldly. And we do that courageously. And we do that transparently. And we do that with the aim of treating healthcare workers so well so that they can treat patients so well. We want to show them the example of what they should be doing in hospitals.
And you do it sustainably. Before Mariam comes in, just another question on healthcare workers. I know we need to move to health access. Yes, you've said that you've had the conversations, and by all accounts, from here on, they should be able to carry out their services because their needs have been met. The worry is whether it is sustainable. And maybe you can speak to the structural change you've made to ensure that the strikes do not come up again, that they are not disgruntled again. Just speak to that structural issue that you've addressed.
What we are doing is to ensure that we institutionalize these issues around internship, we institutionalize the issues around CBA implementation, we institutionalize the policies around the health workforce, and of course, we are engaging with the National Treasury. So far, the Parliament has been extremely supportive, both committees, the Departmental Committee for Health that is also chaired by Dr. James Nyikal, again, another highly esteemed professional in the sector who understands the issues equally. And with the engagement with the Cabinet Secretary and ourselves, together with myself and the PS of Treasury, we are ensuring that we speak the same language with the National Treasury, we speak the same language with the National Assembly, because those are the partners that we need to make it sustainable. And so far we are speaking that language so that we institutionalize it, we make it very clear within the budgets, we make it very clear within the policies. This is what must be done. But I wanted to go to the two other pillars before we go to access.
I wasn't done with health financing, before you go to the other two pillars. I wanted to just get into budget issues as far as healthcare is financing. How much did the ministry need from this year's budget initially? So
if you ask me the total budget that we need for our healthcare in this country, it's around 550 billion.
How much
Yeah.
did you ask for? 400 and?
What we call the sector proposal
Yes.
is around 400, around 450 thereabout. Yes.
How much did did healthcare receive as a whole of the national?
I think around 150.
Right. That was my question. We need 540 in your own estimation, 540 billion shillings to finance healthcare. In your sector proposals, you asked for 450 billion. That's what was proposed, but got 150 billion. How do those numbers work? We have to take a short break in just a minute. But yes, how do you make that work for a quarter? Basically.
You
of
know,
what is required to
if
The
run.
120 for Ministry of Health.
If you've asked for,
Or is it for
if you
county?
asked for nyama and chapati, yeah, for dinner, okay, but you got ugali and boga, will you eat? Will you be full? Will you sleep?
Except healthcare is not really.
To say.
It's not chapati and boga. We have
No.
to take a short break, but
Yeah.
hold that
What are you
thought.
saying? You're making do with what you got.
We have to give the best healthcare that we can give with the resources that we have. But we are making strides. And that's why today is very important for us to tell people that they must register and contribute for their social health insurance fund. And I'm coming there.
Okay, hold that thought. We'll be right back with Dr. Omar Oluga. Hashtag is Fixing the Nation NTV. If you have any questions regarding, Shift, SHA, onboarding, the workings, any comments or feedback, of course, our number is 0719038858. We'll be back after this.
Later, Ian Muli Oluga has mentioned Taifa Care, so he's eager to find out more about what it is. Domi Rop has already asked what next for UHC staff. I think you've spoken to it. Ask him about the UHC PNP letter and gratuity. I hope that makes sense. It wasn't said in full. So those are just some of the questions and comments coming in.
We have to clarify this over and over again. And because you're in the media, I think one of the things we cannot get tired of is talking to people. So if your contract has been converted, so this is a contract. So you have a contract that says you're 3 years. But then somebody tells you, okay, so instead of having you for 3 years, I think I'm going to have you until you retire and I pay you a pension. Tell me where gratuity comes in. I think we may need, I have a union background and I am extremely knowledgeable about the Employment Act, even more knowledgeable about the Labor Act, even more knowledgeable about the Retirement Benefits Act. So gratuity doesn't come in there.
What were the terms of the contract, the 3-year contract?
So
The terms were that there was going to be gratuity at the end of the 3
So
years.
there was not, I think you may need to get a copy of the contract and
Okay.
read it on air.
Was that there?
It wasn't there. So what happened is that the contract was for 3 years. And then the government found that they still needed these workers. Of course, we need a lot of workers. So they said, let's extend this by another 1 year. So that is still the same contract because I've extended your contract. Then they said, okay, I'll still need these guys. Let's extend it by another 2 years. So that's 6 years, okay? Now, the Public Service Commission, having looked at the extensions, said, wait a minute, I think it's not fair to have these contracts in this manner. Let us consider having a gratuity. It's the same government that said that. Now, gratuity, you get gratuity when you do not get a... Gratuity is the same as pension, when it's one or the other. I mean, the law is very clear about it. Gratuity is the same as pension. So you can't get gratuity and then get a pension. You get one or the other. And it's usually calculated as 31% of your annual gross salary. This is the law I'm talking about.
From what point?
From the point that you are employed. Now, if,
Under the permanent
if we
contract?
pay you gratuity, this is, and I think the UHC workers should hear me and hear me extremely well and then go read the law. I think this, and I'm from a union background, so I know this very well. If we pay you a gratuity, what you're saying is that we are saying goodbye to you. So what that means is that we will take our money and then do advertisements and employ any other Kenyan out there. If you are the same person that we are transitioning from a contract to to a permanent and pensionable, there is no gratuity language.
Okay. Into the conversation again of the pillars of
Yes.
universal health coverage, and you said one of them is financing, the other one is healthcare. Of course, there is service that is important, and I know you're going to say the fourth one is the system, the digital.
The digitization,
that we did-
and the
we
third
did-
one is the commodities.
It's commodities.
Mgonjwa apate dawa kwa
Yes.
hospitali. Yes.
On the issue of the financing,
Yes.
this is where we have three funds
Yes.
being governed by one social health authority.
Yes.
Social Health Insurance Fund,
Yes.
I contribute to it.
Exactly.
There's a Primary Healthcare Fund, I
a
contribute to
taxpayer
it
fund.
by paying
Taxes.
tax.
Yes.
And there's the Emergency,
Chronic and critical illness, ESIF.
Fund.
Yes.
It's a long one, that one
E-
always confuses.
Double C.
ECCIF,
Yeah. ECCIF.
Okay.
Emergency,
chronic,
chronic,
critical
illness. So
Fund.
emergency is things you don't plan for. Chronic are diseases that have a long term, more than 12 months as per the law again.
Okay.
And then critical illness is ICU, HDU.
Okay.
Yeah.
So what does that mean? For those other two funds, the ECCIF and the Primary Healthcare Fund, it is exchequer funded,
Yes.
right? So no direct contribution.
Yes.
It means that if I go to a level 2,
Yes.
a dispensary, a health center, and some level 4 facilities, I should access my services and go home.
That's exactly walk in, walk out.
Walk out.
Level 2, level 3, in all private, in all public, and in faith-based facilities.
Okay.
Level 4, in the government facilities. You walk in, you walk out. For primary healthcare services.
Now, this other one for the emergency chronic critical illness, that's where now the discussion starts coming in. People who are undergoing chronic and critical illness treatment are saying that in some instances they are being asked to pay. Is that true? Are they required to pay?
We have been, engaging on understanding of the package to Kenyans. And I think we have to do more to make Kenyans understand what the package is. And we've found a lot of problems with hospitals. There are many hospitals that have issues. Either they did not sign a contract with SHA, or they do not have that service as part of their contract. And so they tell patients that SHA is not paying so that they can get cash. If you go to facilities that are contracted, and out of 14,000 facilities, 10,000 facilities are contracted by the Social Health Authority. And if these facilities are level 4, level 5, and level 6, and they have the service, and I'll talk about that. For example, the emergency is level 4, level 5, and level
6.
Level 6. Okay? The Social Health Authority will pay for it. And what we are encouraging facilities to do, particularly government, there will be no additional charge. In the private sector, we are working with a number of facilities. I think you've seen us sign a memorandum of understanding with the Aga Khan University Hospital. You've seen us sign a memorandum of understanding with Nairobi Hospital for specific chronic diseases, such as, for example, kidney transplant, cardiac care, that you will pay nothing on top of what the Social Health Authority is giving the hospital. Now, there are a number of private facilities that their charges are still higher than the tariff that the Social Health Authority is reimbursing them. And so they're asking patients to top up. But this is something that we want to engage and educate the members of the public, that why would you go where you're being asked to pay more when there is a place that you can go and be treated without having to pay anything additional?
I'll tell you why, Daktari. Because I don't know all those things you're saying.
Exactly the
As
point.
far
And
as
that's
I'm
why, and
concerned.
that is why I'm here. And that is why we have to work with you very closely, and that is why we have to disseminate this information. And very soon we will publish the list of all the hospitals and the services that they have been contracted for.
And in the
Very soon is very
is-
soon.
Yeah,
When?
how soon is very
So
soon?
we are engaging on two things first. One, of course, the system that, the biometric system that was launched 2 days ago, the previous day, so that then we ensure that every single facility has a digital mechanism. And you've seen us also rolling out digitization in the public health facilities so that we match the what we call the hospital management information system with the digital health super highway, so that we can see in real time that Janet is in hospital X. Now, once we do that, then now we can easily tell you that in hospital X where you are in, this is the contract of the Social Health Authority, because it will come as you are getting the service, so that you don't have to go through, today if I were to publish for you the list of facilities, for example, that the Aga Khan University Hospital, Nairobi Hospital, or any other hospital, let's say Nakuru PGH, it will be a booklet. So it will be quite a punishment for patients who are seeking care to start
So what
sieving
happens to
through.
them now?
But
Right.
In the meantime.
no,
But it also requires like tech
in-
savvy, which
yeah.
a lot of people may
That
not
is
have.
exactly what is happening right now. We have now uploaded the product catalog. The product catalog is the list of all the drugs that you can be prescribed for as long as you are within the Republic of Kenya. These drugs have been approved and registered by the Pharmacy and Poisons Board. So the drugs have already been uploaded. We have uploaded the list of any healthcare worker who can see you, who is trained, educated, graduated, registered, and licensed, and retained to practice at this moment.
Uploaded on what platform, just to be clear?
The same platform of the digital health superhighway, what we call the comprehensive integrated health information system.
Wow.
So any healthcare worker, if Dr. Luga, and I'm properly retained, by the way, so you can use me as an example. I am retained in the register. If you go to search for, if Dr. Luga is to see you today as a patient, Dr. Luga is now in the system. If I am not retained, if I am not registered, you will not find me in the system.
Right.
Now, these two things have already started. The third thing that has started is the list of all the hospitals in the country, and now they have even been geomapped. They have been geomapped in terms of location. So you can no longer claim, the idea that people were sending messages or what we call one-time password from one end. It's no longer possible. So the hospital has been geomapped to its location where it exists. Dr. Luga, if I work in Mbagathi Hospital, I have also been geomapped to Mbagathi Hospital. So I cannot go across and do anything. These are the things that are happening in the system. So the hospital has been uploaded. The drugs have been uploaded. The health worker has been uploaded. The SHA services have been uploaded. Now, what we are waiting to match with the SHA services is what the hospital offers.
Okay.
So that then we can match that this is what SHA has in their package, and this is the list of services that the hospital offers. So that this confusion of, a hospital, instead of telling you we do not have this service or I'm not contracted for this service, they tell you to pay for it, it is ending.
Mariam,
Let me-
this
And
sounds
it will
like
end
Otieno
by-
Kajwang. Kisungu kubwa.
Hakuna kizungu kubwa hapo. Nimesema
I'm even still on the basics.
Yes.
Let me start with when accessing, primary healthcare, emergency, chronic, and critical illness, right? Healthcare. Do I need to be on SHA? Do I need to be a member of SHA, a registered person?
yes, you have to be registered. Right now we have 25.
Sorry, I'm just going back again. It's
Registered, not
Exchequer-
necessarily paying.
Right, that's the thing. Because it's Exchequer funded. So it's meant, is it not for everybody? And is it not for emergency care, especially?
I think
Chronic
this
and critical
is
illness.
very important. So the Exchequer has given 8 billion Kenya shillings for 3 functions. One is the emergency care. The emergency care is 100% Exchequer funded. Okay. The chronic care is funded partially by that fund, and also the
Critical illness.
the critical illness. So, for example, I'll give an example of cancer, but this is not this is just details. So,
No, let's give us the example of cancer.
so the example
Actually,
of cancer.
let's use this example.
Yeah.
You saw the story that we were airing on NTV, and we had it on Nation, about a 70-year-old man called Gatamu Waigwa, who has stage 3 prostate cancer. He must get some medication that's costing him about 200,000. First, he was told that he has depleted his 400,000 oncology cover. Okay. Then, he was told that SHA has refused to activate his critical illness fund because it had allocated 150,000 shillings. Now, for another 150,000 shillings, he has to wait for the next financial year. Now, let's use that as an example.
That is
So I'm
what
70 years old.
what I needed to
I have
explain.
prostate cancer.
So this thing is based on, first of all, mathematics.
Okay.
So we have a number of diseases. By the way, actually, what I need to explain here are two things. One is, what exactly do you determine to pay for? So there are two things that you need to pay for. Number one, things that if you don't pay for them, the person dies. And number two, things that if you don't pay for them, the person goes into poverty. I hope we get that very clearly. So in this, our mathematics of the money that we are collecting, SHA is simply a payer for healthcare.
Yeah.
So we want to cover everyone. That's the first principle. You want to cover everyone. Okay? Number two, you want to cover everyone equally. You want to set a level playing field, so equity. Okay? Number three is that you want to make sure that the health system is getting good outcomes. So that means that you want to prevent deaths, and you want to make sure that you also prevent diseases, but at the same time, you want to restore health.
Yeah.
So if you look at these principles generally, the best example is, again, cancer and dialysis, for example. If today you do not get dialysis and you need dialysis, chances you will die is 100%. So the government has to pay for that, so that, number one, you don't die. We want better health outcomes. Okay? Number two is that if you are to pay for dialysis by yourself, you will pay 1 million shillings a year. If you calculate the
number of
sessions,
sessions
yeah, it's actually 1.1 million shillings a year. So if you take any ordinary Kenyan from a village, 1.1 million shillings means that you will sell your land. Even if you have a lot of land, you will sell your land for the first 1 year. The second year, you no longer have land. Okay? So we must make sure we protect you, one, from dying, and two, from going into poverty. Okay? And then, of course, the dialysis must be quality, so that you can still live a quality life, be productive, go to work. Okay? Now, those are healthcare system issues. Now, when we determine what to pay for, those two things are critical. Now, there are some things, and I have to say this, for example, in the outpatient, there are some things that you may go to a doctor, you may be required to pay 500 shillings or 200 shillings, okay? It's a struggle for many Kenyans. It's a pain. You may ask Eric Latif, you may call Oluga, help me with 200 shillings, I pay for it. But it will neither make you die nor go into poverty. For example, if you're having a common cold. I hope you're getting when you're doing the...
We see the distinction.
Yeah, and so when you have little money, when you have just enough money, you have to make very difficult choices on what to pay for. This is what goes into what we call the Social Health Authority Benefits Package.
Right. Just before we
and
get
so
to that,
every single thing
Dr.
on that
Oluga,
list prevents two things. One,
death
what are Kenyans...
abject poverty.
Exactly.
Tumekuelewa. Death and abject poverty. But we're going through, for example, the cost of what it takes to treat some of these chronic illnesses.
Yes.
And the benefits
and
package,
I wanted to
even
explain
up to
that
550,000.
if you just give me that. So for example, the average cost of treating cancer, the average cost of treating cancer is around 600,000 Kenyan shillings. Some cancers, you treat them for 200,000. Some cancers is 10 million. I want you to get me very clearly.
Okay.
So some cancers you can treat for 10 million shillings. Some cancers with 200,000 shillings, you're good. Now, if you take all the 45,000 Kenyans who have cancer and you look at the cost of treating cancer, whether it's 10 million or 200,000, it will be 600,000. So if you're doing what we call actuary, that is a calculation, because this is based on numbers,
So
but
what
it is
happens
also
to the
based on
Kenyans
preventing
whose
death and
cost of
abject
treatment
poverty.
goes to 10 million shillings.
That is the point I'm coming to. So the Social Health Authority and the benefits package, and now, by the way, there is a university that has been appointed. This committee is chaired by Professor Jaoko. Experts that are now going to be doing that calculation and engaging with Kenyans, and it is now independent from the Ministry of Health and also independent from SHA, so that then it can be determined from a very objective perspective. But the principle is that the average cost of treating cancer is around 600,000. You may have one cancer that just with a surgery of 50,000, you're good. Another cancer, you may require a lot of treatments that go up to 10 million. But the average cost is 600,000. So I talked about equity. So first of all, you must cover everyone. Okay? The one that costs 10 million may be fewer people. Okay? The one that costs 500,000 may be 90% of the people. And we are also looking at the most common cancers. For example, our top 3 cancers: number 1, breast cancer, cervical cancer, prostate cancer. Okay? So if you have any of those 3, the treatment will certainly be less than 600,000. Okay? I mean, when you're looking at the individual cost,
the cost of breast cancer,
he is the chair of the National Cancer Institute.
It was actually Dr. Bosire, not the chair of the National Cancer Institute. And we took one of those more common cancers, which was breast cancer, and did just one cycle of treatment, and that came to 2.5 million Kenya shillings. We broke it down I think
that is
mammograms,
no,
chemo.
that is the rarer case. You know, I think that is the exception rather than the norm. That's the exception rather than the norm. If you're looking at the norm and you take any average patient with a breast cancer, for example, they may need 3 things. Okay? They may need, number 1, surgery. Number 2, they will need radiation. Number 3, they will need chemotherapy. All of these things, they will need them over years. If you're looking at the cost in 1 year, and you can take an average of 10 patients and look at what is the cost, for example, of either removing the cancer or removing the breast, it will cost you between 120,000 and 180,000. That is the surgery.
For the year. For the surgery alone.
For the surgery alone. If you're then you go through this the sessions, the radiation sessions. Again, that may cost you anywhere between 21 sessions, 28 sessions. And if you're looking at the cost for that, again, around 200,000. And then you're looking at the chemotherapy, you know. And so I think we have to look at the larger numbers. You know, we are working with the larger numbers of the whole country. So I wanted to make the case that if you are treating cancer, for example, and you subjected an ordinary Kenyan to 600,000, again, they will either sell their land, sell their cow. Most people don't even have land worth 600,000. Or they will die. So our most important role right now is to cover the 99% in that group. Now, of course, there is the exceptions, and those are the exceptions that now the Benefit Package and Tariffs Advisory Panel that is chaired by Professor Jaoko is now going to engage. Is there a better way of doing it? And we invite all Kenyans to now give these views. But I think the principle that is very important is that we want to prevent the majority and the most important cancers that we have, for example, the most important diseases that we have, the surgeries that you require. If you required a knee replacement surgery today, if you had arthritis that is so debilitating that you cannot go to work, and you require knee replacement surgery that is around 270 or 300,000. You know, SHA should pay for that because we want you to be economically productive.
So SHA is not paying for that now. In the meantime, okay, so right now what it sounds like you're saying, hang on, is these are also work in progress.
No.
It's you see, the conversation we're having is a majority of Kenyans, even after this conversation.
What I'm saying is what SHA is doing. I'm not saying what SHA is not doing. I'm not saying what SHA will do. This is what it is doing in present. I'm using the current example. What I am trying to explain is that there are a few exceptions few exceptions.
What happens to those exceptions today who are watching? That's what I'm trying to understand. Because
so the exceptions are still covered.
And I still worry about when you say exceptions, because from just anecdotal knowledge, you don't hear many cases of people who go through cycles of treatment for chronic illnesses totaling up to 550,000.
But by the way, let me say this publicly. 5 million Kenyans have gone into a hospital, gotten treatment, and not paid a single cent because SHA paid for them. There are Kenyans who've gotten to hospital and had cardiac surgeries, and SHA paid 950,000, 0 shillings added, whether it was at Karen Hospital, Nairobi Hospital, Aga Khan. There are Kenyans who've gone to a facility and had surgeries worth 500,000, and SHA paid for it. No single thing added. 5 million Kenyans. But we do understand that there may be 10 Kenyans or 20 Kenyans, okay, who may have gotten, their treatment was worth, let's say, 700,000, like the case that you highlighted. You know, SHA paid for up to 600,000, okay, but there is this 100,000 that was remaining. But we want to make it very categorical that 99% of Kenyans who walk into a hospital and get treatment walk out without having to be asked anything. But we appreciate when the media also highlights some of these exceptional cases, because these are the cases that now needs to be studied in this broader actuarial calculations, so that when we model our what we call tariffs, then it is also important that we cover everybody. But it is very important that we know that there is just enough money to
cover so much.
To cover
48,000 Kenyans currently undergoing cancer treatment. In what, from my estimation, how many of them are going to hospital and going back home without paying a shilling?
95%.
So these other 5%, speak to them.
These are the
5% who are right now dealing with cancer. They're going through treatment, but they have to pay out of pocket.
So, you know, one of the things that we've done, 2 things. One is that the law establishes the benefit package advisory panel that is independent and that is now collecting all those views to help them. So help is here. But number 2 is that we have the call center, 147. And by the way, somebody talked about endless calling. 147, the call center. Every individual case is being attended to. And SHA is based on the principle of equity. SHA is based on the principle of access. There is no single Kenyan who has an issue, who raises that issue that goes unsorted. And that is something that we want to assure the public.
For now, I think you can't categorically say that, because I'm sure there are people who make calls and the issues are still not sorted.
Covered,
but
has tried to call,
yes,
has tried to write, and right now he is having to pay out of pocket.
So
there are many who are paying out of pocket. And unless you're saying that if you call today, then tomorrow you'll be able to go to a facility.
If you call today, your case will be attended. And let me, you know, one of the things that I think I want to explain very well, and I again want to talk about the exceptions. For example, one of the, let me use the word challenges, is the fact that we have to cover everyone. So if we are paying 600,000 and we ask you that we are going to pay for you 600,000, please top up 20,000 shillings. I think that's something that people should sort of understand, because we also don't want to start breaking the law. You know how NHIF went into bankruptcy? Is because Dr. Luga can be paid for 1.5 million, but the common man who doesn't have access to those explanations can't get that.
Doctor, we are completely out of time. We'll see if you can leave us with any other critical information. Dr. Omar Oluga, PS Medical Services, having a conversation.
You have a couple of questions to answer.
True. Right.
About 10 extra minutes out of this. Let's just take this break quickly, come back, and then we talk about, just as we conclude. Back in a moment.
Right. We're getting back now in conversation with, of course, Dr. Omar Oluga, the PS for Medical Services, talking about SHA and Taifa Care, unbundling it, understanding it. The comments are coming in really quick and really fast, Daktari. So, for example, we'll establish, no, not eCitizen, sorry. What next for UHC staff? You've answered that. Someone says, this is Teresa, says, I lodged a refund claim with SHA on the 4th of March for the late baby Ariana through the former CEO. But to date, I have not received feedback, let alone the refund itself, despite many promises. That's Mama Ariana speaking. And she's texted the same Jano. And she's spoken about this. She's even called live while she was in India when baby Ariana was still alive and receiving treatment. And the reason that she had to go for the refund as opposed to the payment was because the hospital that baby Ariana was in refused a guarantee of payment from SHA because they had debts from NHIF. So that speaks to many things. One, the fact that no one has talked to her about this refund claim, no one has gotten back to her. And that's the case for so many other people. There was also Mzega, I want to get his name right, but Mzee who was suffering from prostate cancer as well that Eric was speaking to. Same thing, he says, I've gone to the offices, I don't get a response. We'll need to answer that, basically, what's happening there. There's also questions of the fact that SHA shift praise and worship, okay. This is Samuel Macharia saying, SHA is not working at Naivasha Sub-County Hospital for outpatient. We are now opting to go to private hospitals and pay, yet SHA is being deducted. That's Samuel Macharia's experience.
Naivasha Sub-County?
Yes.
I mean the county hospital or sub-county?
Sub-county. I'm a sub-county.
I think that, that we can pick up with Nakuru because it's supposed to be working in that hospital. And I think there is...
what's your name? Is feedback? There's a few more. Esther Kiari is saying, which SHA? Can he listen to the questions? This is what people are living through. I think that was what Ian Muli was also saying. Users of SHA are telling you hiyo kitu haifanyi kazi. Samuel Macharia again. Users of SHA saying it's not working. Yes.
No,
that's more or less the same sentiment.
I have a number of uses. I pride myself in in being a very ordinary Kenyan of extremely humble background. And I live the life of the very ordinary Kenyan. And I get a number of Kenyans who, in our interaction, tells us that SHA is working. What we are not saying is that there are no challenges. That we are not saying that. We are not saying that this is a one-stop solution, that the SHA is now everything in the healthcare system. As I had noted when we were beginning, what we call the total health expenditure, that is, ile pesa yote sisi wa Kenya tunahitaji, ndio mtu yote akona ugonjwa, atibiwe, bila kuingia kwa pocket yake ni 550 billion. Hiyo pesa yote tunahitaji kama wa Kenya, 550 billion. So that irrespective of the disease you have, you can be treated without having to think about how you will pay. So the day that Kenya will figure out how to get the 550 billion, maybe it will be slightly more. That day, every Kenyan will say, okay, I can now be treated. Now, let me break this down. The government is putting money through various mechanisms. So the government is putting money through salaries of health workers, for example. The government is putting money through the county government allocation. Yeah. So out of the 400 billion going to the counties, 87 billion is still for health. It's the one that is going to those facilities to buy medicines, that is still government money, it's taxpayers' money. The government has also put in primary healthcare fund, 13 billion. ISIF, 8 billion, so 21 billion in total. The government is also putting money through other mechanisms in the budget for the Ministry of Health. Okay? So if you add all of these things, including the money that we have in our private health insurances, including the money that we have in our medical funds. For example, there are companies that they don't have private medical insurance, like Central Bank, but they have a medical fund. If you add all of that for the country, we are doing roughly about 325 billion. Okay? So we still have a 200 billion gap. Now, this 200 billion gap, there are two ways in which it is sorted out. One is through donations, donors. So, for example, we get what we call donor funding into the healthcare system of around 87, around 81, 86 billion there. I think the numbers are confusing me a bit, but it's roughly about 80 billion. And we are looking at the donations in the total. So HIV, malaria, TB, vaccinations, Gavi gives us around 7.5. All those things, if you combine, they're around 80 billion. Then the other one is what we call out-of-pocket expenditure. What we are discussing here and what Kenyans, I think, are pushing hard on is the out-of-pocket expenditure.
Yep.
And what I am saying, because I have to be extremely truthful, is that in this discussion of balancing the mathematics of the money we have, what makes people die that we must stop them from dying, and what makes people go into poverty, there is still this gap of out-of-pocket expenditure.
To the tune of 120 billion.
Exactly.
Okay.
Are you getting what we are saying? And this is a very important conversation because it is the responsibility for all of us. Okay? There is only so much you can ask people. And I wanted to give you, for example, how we came to the 2.75% that people are paying, for example, the people who are employed. Previously, and I had that
Just if we get to the
Yeah.
2.75,
Yeah.
I wanted to ask just about specifically that Mama Ariana case, because I wanted to tie it to something.
So-
but the
so-
guarantees of payments are being rejected by hospitals outside because of the NHIF.
Yeah,
debt.
so there were two issues.
Let me finish.
Yeah.
Even locally, there's hospitals that are on their knees because they're in large debt because NHIF owes
Which
them
one?
money.
Tell me one.
The RUPA says there are some facilities that have closed.
Tell me one. Tell me one.
They have you engaged with the
The
RUPA?
rural,
No, tell me
RUPA are
one.
your friends, Daktari.
Yeah. Lishanga is my very good friend.
Yes.
Tell
And-
me just
and you deal
one
with them?
hospital. Just one.
There are hospitals that are owed over 30 billion shillings, some claims dating back to 2017.
No. All hospitals
Are
in the
owed
country.
money. So-
Wait.
Okay.
All hospitals in the country, all of them, had some contracts with the National Health Insurance Fund, now defunct.
Yes.
The total debt for NHIF is 33 billion. 33 billion. Out of this 33 billion, 90% of those facilities are owed 5.6 billion. That is the small facilities that are owed 500,000, 5 million. And the president already made a declaration that any facility that is owed 10 million shillings and less, and this is 90% of them, amounting to 5.6 billion, will be paid. Now, the same facilities went to court, and the matter is now in court. The court gave us an order, don't proceed. Then we were wondering, because we wanted to do the verifications.
Owed less than $1 million
No. The facilities
as a whole.
somehow went to court because they don't want us to verify the NHIF bills. If your bill is clear and you know that you offered the service, why would you not want it to be verified? Because we appointed a verification committee that is chaired by Mr. Oje. And this verification committee, when they started their work of verification, they called the facilities to just look at the file. So if you
What's
claim
the merit of the case? Why did they go to court? Is
the
it to
merit
stop the verification?
To stop the verification. And the court told us,
Halt the
Halt,
verification.
the verification.
Until we finish this case.
and we said we want to verify and pay. So we can't pay because we have not verified.
So this is where public expectation and government delivery is at a crossroads.
Yes, and I think it's more of, let me use the word, these are sub judice cases, so we may not discuss them. But sometimes it almost looks like sabotage, and it is not in good taste for the facility that is suffering. You may find one or two facilities that have issues. Maybe their bill is, as you're saying, their bill is maybe $1 billion or so. There are facilities that say that they are owed But they're also not the facilities that are suffering. The facilities that are suffering are the facilities in the rural areas that 10 million shillings means so much for them. But that facility is also not the facility that has gone to court. You know, we as Kenyans, we have to look at the whole equation. And I think it's very unfair.
But as a Kenyan going to a hospital, I don't know that the nearest hospital
and that is why we have to look at it for what it is. What it is that somebody may go to court, the court gives us an order, and it affects the end user, it affects the Kenyan that is going to the facility. That's why it's very important that we work in an ecosystem
and we have a conversation
where we all understand where we are going.
Have you reached out to the facilities?
We've had a lot of conversations.
Are you having conversations on the site?
We're having a lot of conversations.
You know what's running through my mind, Daktari, and I've got to be very blunt here.
Yeah.
Mchezo wa town.
Sio mchezo wa
town here, coming from
Eric, you know us very well. I think
that those who owe do not want to pay, and so those who owe sponsor a court case, so there's an injunction.
No.
Mchezo wa town.
No. The injunction. This is a case by one of our good friends, activists, Dr. Magare. So Mchezo wa town, I think you can call him here to say why he went to court and what.
For me, what's going through my mind is patients. This context almost doesn't matter to them. No,
and that is why the shared responsibility that I talked about is very important for all Kenyans.
Let me ask you, Daktari. Right now, we're speaking to Kenyans who are really ill, right? They just want to access service. Earlier, you talked about the fact that there's some hospitals that have not signed an agreement, right? What did you say? First of all, do they have to? Is it mandatory? It's mandatory, but they haven't.
They haven't.
Okay, and therefore it's affecting their ability to do services. People have to go there and pay out of pocket, even though they shouldn't. So that speaks to healthcare rights. So again, I'm speaking to the person who's watching this, who tomorrow or today or this afternoon is going to go to Said Hospital.
And then, that hospital will not tell you that they have not signed. What they will tell you is that SHA is not working. And then they will be very keen on this narrative. And because they want to force people to pay out of pockets. And we don't want people to pay out of pocket. And this is where we are closing in.
Let's take a caller. For me, it's just like, okay, how is this person supposed to verify? They'll still pay out of pocket because they don't know
I mentioned that will be verified.
Dana, what's the caller's name? Dana is our director. Caxton from Butere. Our fixer from Butere. Caxton, good morning. You have a question for Daktari?
Morning to you. Jambo Daktari.
Jambo, habari Caxton.
Njema sana. Mimi nauliza namna hii mambo ya afya. In fact, if you people can work out it well, it can be free. If it is working in some other places, why not in Kenya? For instance, why should it's good for the women that fistula is free. Why don't you make it also this prostate cancer for men? Why don't you, let it be free?
And so no need for...
Asante Caxton. So,
Karibu.
Kwa saizi, Wakenya ambao wako na prostate cancer, na nilikuwa nimesema, 600,000 is more than enough for the treatment in a year. Per year. But you will find, and you know I'm a physician, I'm a doctor. I mentioned I am fully retained, so I also understand the practice of medicine very well. You will find there are a number of medications that you need to give for prostate cancer, okay? So there are medications that are within this limit, but there are also what we call novel. Novel is very new molecules. Those new molecules may not be mandatory or as required, but then you find somebody is on that medication, and that medication alone costs, for example, 140,000. One medication. So, you know, we also, and that is why, and I hope you got it from the chair of the National Cancer Institute, we launched the protocols for the treatment of cancer. Because you find, you go to a hospital, and by the way, we have to do a lot of things at once. We have to do a lot of things at once. Because for us to make sure that your 600,000 is value for health, what we call value for health, we also must look at what are the list of medications that can still treat you within this 600,000. Because you find that doctor is prescribing for you a medication, one medication, that is worth 140,000. You get 3 injections, you are already at 420,000. 3 injections for prostate cancer. But your cover is 600,000. That is why we have also done the protocol. So that the doctor has to work within the protocol. So that the 600,000 is enough, so that you don't get people saying that my prescriptions is outside what SHA is paying. That is why we've signed with Roche Herceptin. Herceptin used to be 120,000. Herceptin is a medication to reduce hormones, that for those that we call hormone positive in breast cancer. It used to be 120,000. So 3 of them, Psycho, is 360,000. We have now reduced it to 40,000 from 120,000. Why? So that your cost of treatment of cancer is within our 600,000. That is why kidney transplant used to be 1.2 million. Now we've signed with Aga Khan. For the surgery, it is 700,000. So that the 1.1 million that SHA is paying is still within the cost. So Kenyans, we appeal to you. We are doing a lot to make sure that, as we say that this cost is 600,000, we are also trying to push it back to make it as free within that 600,000. So we have just signed what we call the Accord for a Healthier World with Pfizer to get 140 products, 140 medications for diabetes, for hypertension, for asthma, for epilepsy, so that right now, if you are a diabetic patient, the cost of treating diabetes per month averagely is 5,000. So in a year, you require 60,000. That's diabetic patients. We have 800,000 diabetic patients in the country. That is 48 billion. Just one disease, 48 billion. The same with with hypertension. The average cost of hypertension is 3,500 for you to take your monthly medication. Again, we have around 900,000 diabetic patients in the year. If you multiply it, around 36 billion.
And hypertensive.
That is only hypertension. So we are saying that, for example, in SHA, we are saying that the laboratory is covered up to 1,400. Now, what we are doing is what we are doing now with this pharmaceutical, signing the MOUs with the hospitals, making sure that within the hospital costs, we are also reducing it. That is why tomorrow we are also launching the National Equipment Service Program that is putting the cancer machines, including the radiotherapy machines that people have been lining for. Because one radiotherapy machine costs 300 million. But now we are saying, how can we put this out of our budget so that somebody is going to buy it? The government is not buying it, national government, the county government is not buying it, Kenyatta is not buying it, but it is covered within that fee, what we call the fee for service. So if SHA says that each radiotherapy session is 6,000, they cover within that 6,000. So we are trying to do everything across the board. So the financing, we are telling you, Kenyan, please register with the Social Health Authority, dial *147#, follow the menu, please register. Please pay up your social health insurance fund so that we have a pool of money to pay for your services. On this other side, we are ensuring that the healthcare system works within that amount that we have put.
You recognize something, that on a daily basis you are doing things, you're iterating, you're learning, you're moving, okay?
Yeah, because we have to do that.
I want to head back into October last year. We rolled out SHA.
Yes.
So it's been what?
It's been 9 months.
9 months.
Yeah.
But before that, October 2023, the laws were signed.
Yes.
To roll out SHA.
Yes.
So it's been a year and 9 months. And we are here where we are still now learning and moving.
Let me tell you,
how
Japan.
many more years do we need to keep learning and moving so that a man like Atama
and the law
does not go for cancer treatment?
The law has answered your question. The law already has answered your question in terms of maturity. It's about 3 years for the systems to be mature. But you see, I wanted to mention what we have done in 9 months that was never possible. Right now, people say that 1.9 million Kenyans have paid by themselves.
You know what I'm judging you by?
Yeah.
I'm not judging you by these 9 months. I'm judging you by the 12 months before the 9 months. Because you had 12 months to do all these things that you're talking about, the modalities.
No.
You had 12 months, for example,
Japan has had 60 years.
You had 12 months to have Professor Jaoko in place to actually know how much the services will cost.
The way our system is set up, and Eric, you know it extremely well. You have been here. You've been in this game for a million years, just like myself. You know it very well.
I don't know.
So first of all, is that our laws are consensus based. So you have to go through public participation as per the Constitution. So the laws were passed in October of 2023. You have to do regulations to operationalize the law.
Yes.
Regulations are also legislation. You have to go to parliament, you have to do public participation. Okay? Once you get the regulations, then you have to do the guidelines. Again, you have to do public participation. This is the Kenyan Constitution. This is not anybody's. This is the way the country is designed.
Okay.
In fact, by any standard, SHA has taken the least amount of time in any country in the world. By standard, right now we are doing 7% of the administrative cost, the lowest in the whole of Africa. Global standard, right now the East Africa standard is around 15%. NHIF used to do 17% administration. We are now down to 7%. By any standard, right? NHIF 62 years had what we call 1 million people paying by themselves, or what we call the informal settlement. SHA 1.9. By any standard, SHA has collected around 56 billion. In 9 months, the highest NHIF ever collected was?
We'll pause you there.
Yeah.
We'll probably come back and explain.
Judge that, and I think it's...
no, I think you'll come back for communication is so integral, and people also wanted to know about the revocation of internships for nurses. Unfortunately, we can't get into that now.
Maybe
but
quickly just...
Yeah, in a minute, can you give us an update on why, what informed?
There's some nurses who want to go on internship.
The 3 steps that are important is, number 1, you must graduate. After you graduate means you get a certificate of graduation. The dean of that school, whether it's a nursing school or a medical school, needs to send a list of those who have graduated to the regulator, the nursing council or the medical council. Then the regulator enters you into the register, indexes you, and then sends your list to the Ministry of Health. Okay? Now, people bypassed that system, some people, and got people who are neither sent by their deans or they had not graduated into the list. And that is what the Cabinet Secretary has corrected. And I think it is as clear as that.
Okay.
Right. Thank you so much. That is Dr. Ouma Oluga. We're talking about basically the state of healthcare, a pulse check on the state of healthcare. Hashtag is Fixing the Nation NTV. We'll be right back after this. We still have a lot of conversation to get through, tafadhali, so please don't touch that dial. Tunarudi sahihi, and we'll be talking about public-private partnership with Kefa Seda.